Well, thank you everyone for joining today's mental health forum. Just a few notes before we get started. First of all, this meeting is being recorded, and the forum and all the materials, the slides, etc., will be posted on our website afterwards. So it usually takes a couple days, but you can find them there, or you can send them to people who wanted to see this and have not weren't able to attend at this time. Um, the title of today's session is what to expect when you are not expecting COVID, and on mental health and well-being of pregnant and postpartum women during the COVID-19 pandemic. Archana Basu is going to be moderating this session. She is a research scientist at the Harvard T.H. Chan School of Public Health, and a child clinical psychologist and instructor at Massachusetts General Hospital in Psychiatry and Harvard Medical School. And so I will hand it over to Archana. Thank you.
Thank you, Karestan. On behalf of Karestan and her team, I'm pleased to welcome all of you today to our forum focused on perinatal health during the COVID-19 pandemic. As we know, the pandemic has significantly affected the well-being of people around the world, including the well-being of pregnant and recently pregnant women. So our panel today combines expertise from epidemiology, maternal fetal medicine, and psychiatry to discuss the effects of the pandemic on mental and physical health during this perinatal period. So we have three experts today on our panel. Dr. Sonia Hernandez-Diaz is a professor of epidemiology at the Harvard T.H. Chan School of Public Health. And her area of expertise is in drug safety evaluation from non-randomized data, with a particular emphasis on the design, conduct, and analysis of studies in pregnant women and their infants. Examples of her work include inquiries of the comparative safety of psychotropics for pregnant women and their offspring using real-world evidence from both pregnancy registries and large healthcare databases. She's past president of the International Society for Pharmacoepidemiology and the Society for Perinatal and Pediatric Epidemiology Research, and serves as a special government employee for the FDA Drug Safety and Risk Management Advisory Committee, of which she's the current chair. She's also a member of the NICHD Pregnancy and Neonatology Study Section, and is a member of the Teratogenic Information Services Advisory Board. Through her service to public health institutions, she has contributed to the translation of research into policy and actionable recommendations for stakeholders. Our second panelist and expert today is Dr. Diego Wyszynski, who is the Executive Director of the International Registry of Coronavirus Exposure in Pregnancy and the CEO of Pregistry, one of the world's largest platforms of information for pregnant and postpartum women and their families. Dr. Wyszynski is a medical geneticist by training and received his master's and doctoral degrees in epidemiology from the Johns Hopkins School of Hygiene and Public Health. After postdoctoral work at NIH and an academic career in genetics and public health, he joined the biopharmaceutical company Amgen, where he founded the Maternal and Pediatric Safety Team, the first organization in the pharmaceutical industry exclusively dedicated to the design and execution of pregnancy registries and lactation studies, among others. Since then, Dr. Wyszynski has consulted for a large number of pharmaceutical companies and government agencies in the areas of drug safety and pharmacovigilance. In 2014, he founded Pregistry, a platform that includes digital tools and expert reports on more than 2,000 medications, 300 diseases, and 150 common exposures during pregnancy and lactation, as well as medical experts available to answer questions 24/7 free of charge. Our third expert on the panel today is Dr. Nancy Bayat. She is a perinatal psychiatrist and physician scientist focused on improving healthcare systems to promote maternal mental health. She's an associate professor of psychiatry and OBGYN and population and quantitative health sciences at UMass Medical School. She's the founding medical director of the Massachusetts Child Psychiatry Access Program, MCPAP for Moms, which has increased access to mental health care for thousands of perinatal women, It is also a national model for perinatal mental health care and has impacted state and national policies and funding. She is the director of the Division of Women's Mental Health within the Department of Psychiatry at UMass Medical School. She's also the founding executive director of Lifeline for Moms, which is, you can look that up at lifelineformoms.com, a center focused on helping the healthcare community optimize maternal mental health. Dr. Bayat has had continuous federal funding for research focused on developing and testing scalable interventions for addressing perinatal mental health and substance use disorders in medical settings. With those introductions in place, I'll just outline our plan for today, which is that each of our panelists will present a brief overview of their work, particularly in the context of perinatal health during this COVID-19 pandemic. Following their presentations, we will have the panelists comment on some common questions for pregnant and postpartum women and their families. And then finally, we will open it up for Q&A from our audience for the last 20 minutes or so. With that, I'm going to hand it over to Dr. Sonia Hernandez-Diaz.
Yeah, okay. Hi, I'm going to introduce the topic and then I'm going to pass the microphone to my colleague, Diego Wigniski, and he's going to talk more about the specific studies we are doing. And yeah, now, okay. So as I said, Diego will tell you more about this study, but let me give you some introduction to stimulate discussion on what we know about COVID-19 and pregnancy. And as you know, during this pandemic, millions of women will give birth, have given birth and will give birth in the context of being exposed or being surrounded by a virus for which we really know little so far, because it is a new virus and most of the things we know about it, we are extrapolating from experience and knowledge about other similar viruses from the same family. And that also implies that for pregnancy, the implications of the COVID-19 during pregnancy for women and their offspring are really largely unknown. However, a priori, we had reasons to believe that pregnant women are a high-risk population because of all their physical, mechanical, and immunological changes. They are known to be more susceptible to severe infections from other coronavirus like the SARS and the MERS some years ago. And we know that when they have influenza, the flu, like the H1N1, they have more severe illnesses and higher mortality. So there was some concern, and this lack of information plus the biological plausibility, of course, causes some anxiety among pregnant women, their families, and their healthcare providers. And having information in this context is really needed to inform the guidelines and the recommendations. So what do we know about it? Are really pregnant women at higher risk? The initial information from mainly China that we started to have suggested that they are really not at a higher risk of getting infected than women that of the same age that are not pregnant. And there was no evidence that once they get infected, the disease, the COVID-19, is more severe than non-infected women. The studies from the US, from New York, confirm that the distribution of severity, the mild, medium, severe in pregnant women in Mount Sinai was no different from non-pregnant women. However, recent reports like last week suggested that they might have a more severe illness that has not been confirmed. So far, this is still under discussion, but they clearly, one, get infected, have the disease, but it is not clear that it's worse than in non-pregnant women. But needless to say that even the same severity complicating the pregnancy can really be more inconvenient at the very least when you have to go through C-sections or your pregnancy appointments. And there are cases and reports of women pregnant needing extracorporeal oxygenation and interventions. And there are reports in the press mainly of deaths, maternal deaths during pregnancy in women infected by COVID. But there are, of course, no formal studies showing this, because thankfully the deaths, even when they may occur, they are not that frequent during pregnancy. So this is how pregnancy affects COVID. How does COVID affect pregnancy? It has been shown that women with severe COVID hospitalized with pneumonia have a higher risk of preterm delivery. And it is in part because of C-sections, because to have the delivery under control, physicians tend to have a C-section a little early, but it is also very likely that the reactions, that the cytokines and the immune reactions that COVID produces really triggers spontaneous preterm delivery. And this same reaction usually increases the risk of spontaneous abortions or miscarriages. And that has not been formally shown with COVID-19, but based on what we observed with SARS, it is possible that having COVID-19 during pregnancy might increase the risk of abortion. Another hot question in this topic is whether there is a mother-to-baby transmission during pregnancy. And so far, based on the samples from breast milk from the neonate at delivery, it has not been confirmed that there is vertical transmission in utero to the baby. However, there are newborns infected, and it is most likely that they are infected during delivery when they are in contact with the mother with infection, or maybe getting the infection from healthcare providers around the mom. And so for that reason, when a newborn is born from a mom with COVID, with the coronavirus infection, it is presumed that he is at risk of getting the infection from the mother. And that's why having COVID during pregnancy can affect the plans for delivery. In principle, if this disease is not severe, vaginal delivery would be possible, but if the disease is severe, or just to be very conservative, many women are getting cesarean sections, even when they may not have other indications for them. And to avoid the infection of the newborn right after delivery, the family and partners are typically not allowed to be with the mom, and sometimes not even a family is not allowed to visit the mom. So that clearly changed the plans that the moms had in mind about how they were going to give birth and how they were going to be surrounded by their family and members and friends. So this separation, it doesn't happen in everywhere. There is some diversity. In the UK, for example, the approach is more to keep the mother with the baby. In other countries like China or the US or Israel, the approach has been to separate when the mom has an infection, separate the newborn for at least 2 weeks. And this newborn is also high risk of transmitting in case the newborn has the infection. So they are placed also in isolation so that other newborns in the hospital do not get the infection. And that, as you can imagine, affects the plans for breastfeeding, because if that was what the mom wanted, she is usually recommended to pump during those 2 weeks and to give them in a very safe way the breast milk to the infant. In most places, in other places with a very high level of precautions, the mom is allowed to breastfeed covering her face and so forth. But it affects the experience of breastfeeding. So what should pregnant women do to reduce the risk of getting infected when they are not? Really, what it is recommended for the general public. I'm not going to go through the list of things that you already know, like wearing the mask, social distance, washing your hands, etc. And what should they do if they get sick? The recommendations vary, but again, it's very similar to the rest of us, to stay home in isolation. And the difference in pregnancy is that they are really encouraged to immediately call the healthcare provider, because if they go into delivery and they are sick, all the plans for waiting for them when they arrive and putting them in isolation have to be in place. So it requires a higher level of organization and planning at the hospital and by the mom. And in case they are sick, the pregnant women also have to think what is going to happen if all this happens to me and I am put in isolation and the baby is put in isolation. And some recommendations include to have formula at home in case breastfeeding is not possible. And they also have to start thinking about what is going to happen to their other siblings, potentially, you know, if they have other kids at home that cannot go to daycare and she cannot take care of them and the family cannot come to visit, etc. So all the above, even when I started with the biological implications, at the end, a few women will be affected by the virus, but many more women are going to be affected by the stress of the logistics for the prenatal care, the social family, taking care of other siblings. And as probably Karestan will mention, something that we are hearing a lot from moms is that they cannot have baby showers. So they cannot share their happiness, their pregnancy, their newborn with friends and family members. And then they are also concerned about the economic impact. Many of them or their husbands or partners are losing jobs. So that leads to stress, anxiety, isolation, separation from the newborn, depression, things that we are going to be discussing today. So in conclusion from my talk, this is a new disease. We are still learning. Many of the approaches that we are taking are probably overcautious. And as more information becomes available, probably the recommendations are going to change. But right now, the data are limited and the recommendations will likely change over time. But to inform and to provide like valid and reliable evidence, it is really urgent to obtain that information. And that's what Diego will be sharing with you. So I'm going to stop sharing my slides and let Diego start his.
I had preeclampsia. I think it would have been detected sooner if I wouldn't have had to cancel a doctor appointment. I'm feeling depressed because of unemployment. Financially, my family is struggling. It seems like this corona is gonna make our lives more difficult. I'm worrying about my upcoming baby. There are so many questions coming to my mind. I feel this is end of the world. The whole birth experience was mentally devastating. I am most care for my children and the ability to care for my children. If I get it, I can no longer breastfeed or comfort my kids. If my husband gets it, he can comfort or be with our kids. If my 5-year-old gets it, he's aware enough to be scared, and if he has to go to the hospital, he will be alone. If my newborn gets it, he will be alone and I don't know his chances of survival. The loss of little things, plans and things I thought were important are sad, and sometimes the difference between what I thought my concerns would be 6 months ago and my current concerns make me cry. But the real issues that keep me up at night and keep me praying and scared and vigilant and are the health concerns and what it would mean if any of us got sick. Feeling isolated and lonely. COVID-19 is the least of my problems. What worries me is depression, being pregnant and not having a job. I would like COVID to kill me. But I have a good immune system, and as soon as I have the symptoms, I'll recover quickly. Help me. I need treatment for depression and the job. These are some of the quotes, testimonials that we received in our survey on the well-being of pregnant and recently pregnant women and COVID. Today, I'm going to talk to you about the International Registry of Coronavirus Exposure in Pregnancy. My name is Diego Wyszynski. I want to thank the organizers of this symposium, especially the colleagues at the Harvard School of Public Health for the invitation, and I hope that everybody will get something out of this. The International Registry, what we call IRCEP, is a collaboration between the Harvard School of Public Health and Registry. But it's much more than a study, it's much more than a registry, it's a community. It's a community that has resources, it's a community that provides a platform for pregnant and recently pregnant women and their families to communicate, it's a platform for education. This is the URL, corona.registry.com. And both Sonia and I are the founders and the organizers of the IRCEP, but we have behind us and with us a scientific advisory committee composed of international members from a variety of organizations, government organizations, academic institutions, and industry to advise on the conduct and the execution of the IRCEP, the Pregnancy Registry. As I said before, the IRCEP is a community, and we have amongst different types of offerings, medical articles, where you can go and see all the medical articles that have been published on pregnancy and COVID-19 with a summary and the exact location of where you can find the articles. We have blogs about COVID-19 and pregnancy, also COVID-19 and lactation, COVID-19 and children. We have videos about the topic, and we have interviews, or mostly from truly experts in the field. But in addition to that, we have a chat room where especially pregnant and recently pregnant women and their families can talk to each other. The feeling of isolation and the feeling of sadness, the desperation in some cases, can be minimized to a certain extent when people can talk to each other. The IRCEP has scientific objectives, of course. The first one is to describe the natural history of COVID-19 in pregnant women. Is COVID-19 different in pregnant women than in non-pregnant women? We also want to know if COVID-19 is a risk for major adverse obstetric and neonatal outcomes in women. So we look at women who had the virus. We look at women who know that didn't have the virus. We look at women that had the clinical symptomatology of COVID-19. And we assess their pregnancy outcomes. We look at those newborns, at the offspring. So ultimately, we want to provide women and their family members, clinicians, public health agencies, and investigators with the evidence they need to make informed decisions and recommendations, and to generate data that will allow us and colleagues to conduct studies within this cohort that might inform how to take care of pregnant women with COVID-19. So for this, we designed the International Registry as an observational cohort with prospective and retrospective components. It's a voluntary registry. Participation is exclusively via website and mobile app. And any pregnant woman or recently pregnant woman, meaning a woman who concluded her pregnancy within the last 6 months, can participate as long as they are 18 years of age or older, and they had either a clinical diagnosis of COVID-19 made by any healthcare practitioner, or they had the results of the test for the virus that causes COVID-19, regardless of the result. Participants can enroll in the registry at any time during pregnancy or within 6 months after pregnancy concluded. As I mentioned before, the information is obtained directly from the mother. There's no intermediaries, there's no people answering the phone and taking the answers over the phone. This is all done as what we call patient-centric technology. It's all done via web or via a mobile app. The follow-ups that occur on a monthly basis happen throughout the entire pregnancy and then up until the infant's 90 days of life. And we collect all sorts of information, as you can imagine. Potential confounding factors, information about the COVID-19 infection, obstetric and neonatal outcomes, and information on healthcare access, for example, well-being and mental health. As of today, we enrolled 295 women. As you can see, the distribution by country on the left side, MX is Mexico, US, Great Britain, Philippines, Australia, South Africa, Chile, Spain, and Canada. As you can see, there's a skewed distribution. There's many more people in the US, in South Africa, and in Great Britain, in England, and that's because we specifically targeted those populations. And this has happened only in the last 72 hours. So we are getting an enrollment per day of approximately 100 women. I wanted to finish by mentioning a sub-study on health and well-being during pregnancy that we are conducting with Professor Koenen, with Sonia and myself and my colleagues at Registry. This was a survey that was international. The main objective was to assess the mental health of pregnant women and women who recently gave birth. And at the moment, we are closed for enrollment because we completed our goals of enrollment. By the end of the enrollment, we had 7,561 participants that were collected in 10 days. They are from 68 countries, and of those, 32 countries had more than 100 participants. All continents are represented in this study. And as you can see below, there are a variety of scales that are being analyzed at the moment by colleagues at the Harvard School of Public Health. And hopefully we will have results very soon. Again, if you have any questions, please feel free to contact me at Registry, and I will be happy in a few minutes to answer any questions.
Hello, so thank you for the prior presentations, which really teed up the impact this has on mental health. And thank you to the Harvard School of Public Health for having this forum and also having it focused specifically on mental health, which is, as you've heard already from Dr. Fernandez-Diaz and Wazinski, that it's such a critical part of the impact of COVID-19. So as you've heard already from the two prior presenters, COVID-19 is causing unprecedented challenges in healthcare in general. So one of the things is that it can be much harder to access healthcare, and you've heard this especially from the quotes you just heard in the last presentation. And even if women are accessing healthcare, that care has changed. And you heard again from these examples and some of these examples in the prior presentations, and I'll give a few case examples as well. And part of this is that there's much more telepsychiatry happening. A lot of OB care is virtual. People aren't allowed necessarily to have visitors, and this is all depending on what part of the world someone resides in. And then the other thing that we're seeing is that women have many stressors. Pregnancy and the postpartum period is an extraordinarily challenging time period. And these stressors are completely exacerbated during the COVID-19 pandemic. And some examples include social isolation, financial insecurity, and interpersonal violence. And again, you heard the quotes from Dr. Wazinski on this. And then also some of the coping mechanisms people can't utilize anymore. For example, psychosocial supports and other things that they did, having, and just other daily activities of daily living or other things they want to do, for example, baby showers. There's many, many things that people can't do that meaningful activities or things that they used previously to cope with depression and anxiety in general. And so it makes sense that we're seeing increasing rates of depression and anxiety among pregnant and postpartum women during the pandemic. So the studies are showing that depression is occurring in 1 in 2 of every 5 women. And what we're seeing is that some studies are showing, or the rates are varying between 20 and 40%, but and this is symptoms of depression. And for anxiety, rates are varying between one particular study showed 35%, another one showed 70% of women were reporting symptoms of anxiety. And our group has done a study led by our MD PhD student, Grace Masters. We asked women who screened positive for depression using the Edinburgh Postnatal Depression Scale. And in our study, what we found was that 40% of women reported that their depression had increased since COVID, because we had been following them pre and post before COVID. This is a longitudinal study. And 60% of women reported that it had moderate or severe impact on their anxiety. And then the majority of women reported that it had at least some impact. So it's clearly impacting women. It's clearly causing depression, anxiety, but also exacerbating existing illness. The other thing that people are reporting is that it's making it harder to access healthcare. And one of the things that we're seeing, and we report this in our study. In our study, when we interviewed women, 70% of them reported that it made it harder for them to access healthcare. And we saw that was reported more often among Black women. And in general, we know that race, income, public health insurance coverage increases the risk of perinatal mood and anxiety disorders. And we also know that communities of color are disproportionately impacted by the pandemic. And specifically, women, particularly women of color have experienced acute, long-standing racial trauma. This can include mistrust of the healthcare system. And what we're seeing is this intersection of the COVID-19 pandemic and then the inequities that are happening. And there's very little research on this currently around how that impacts mental health care and about mental health inequities. I'm going to give you a case example. I wish I had more data to present on this, but we don't have data on this yet. Our group is collecting data on this and others are. I'm going to give you a case example that exemplifies one of the things that we're seeing, and we're beginning to see in the data that we're collecting as well. And so when we think of COVID-19, it's a global traumatic event, right? And what we're seeing is that women and their families can experience this traumatic, and this can be worsened when there's health inequities or when people experience racial oppression or trauma. And so I'll give you a case example. So I direct a statewide program called MCPAP for Moms, as was mentioned earlier. And in that program, we provide consultation for providers in Massachusetts that are at the front line serving pregnant and postpartum women. Recently, we had an OBGYN call, and she was calling about a woman who was Hispanic, but the woman said that she was Hispanic and she had a history of depression and anxiety, and she called very anxious. She wasn't able to work because of COVID, and also a lot of the coping skills she was using weren't accessible to her because of COVID. And this provider was calling, and I ended up interviewing. I did the one-time consultation that we often do as part of our program. And when I talked to her, what she told me was that, it was impacted by COVID. She felt very isolated. She had been working, wasn't able to currently do her jobs. There was financial insecurity. And then the other thing she reported was that while she was Hispanic, she said, people perceive me as being a Black woman. And she had thrombocytopenia, which is low platelets. And she was concerned that she was concerned she would get COVID. She was also concerned that because people perceive her as Black, that she would die during her delivery because she thought that people weren't going to listen to her. So the combination of the pandemic, the stressors, and then also this racial oppression this is what her main concern was. And she was had PTSD, post-traumatic stress disorder, related to this, and was extremely concerned about this. And we know that in America, Black women are 3 to 4 times more likely to die in the postpartum period than white women. And so it's understandable and expected that women have these concerns. So this is one of the things that we're seeing is the intersection of the pandemic and also these inequities that people are aware of. The other thing that can happen is that it complicates addressing existing mental health conditions. And it can make it harder to detect existing mental health conditions. So another example is, we recently had a pediatrician call, and the pediatrician called and said, we feel like we have to screen women much more often because they're falling through the cracks. She said, we're seeing people fall through the cracks way more than we ever have. So I asked her, well, what's happening? What are you seeing? She described an example of a woman who had postpartum psychosis that she had a history, she was known to be high risk, and usually she would have been monitored in the hospital and it could have been detected. Usually postpartum psychosis occurs within a few days after delivery. She was discharged very quickly because of restrictions around COVID. Within a day, went home, wasn't detected, ended up going to the pediatrician's office in a psychotic episode, and it became a huge crisis. And the pediatrician felt like I had to screen people early and was calling for guidance around how to do that, because she felt that because of the changes in the healthcare system, and particularly in OB care, that they need to do more in the pediatric setting to fill some of these gaps. And the other thing that makes this really complicated, that even if somebody does get to even if someone is accessing healthcare and they are screened, it's difficult to know what to do with that, particularly for frontline maternal child healthcare providers. Because another thing, I'll give another case example. If we worked with a woman, another consultation, someone who was hospitalized for her delivery, she was COVID positive, and she was separated from her baby and her family, and ended up having, again, she had acute stress disorder because of this, and ended up causing a mental health crisis. And in this particular case, it was clear she had acute stress disorder. It complicates the treatment. And then in another case, we had someone who called, and the patient this particular woman was concerned because she was a dancer, wasn't able to do her dancing, wasn't able to lead the classes. It was a huge loss for her. She didn't actually have a primary psychiatric illness. She was grieving. So there's all these things to differentiate when we're thinking about mental health as it relates to the pandemic, because there's differentiation between grieving and primary psychiatric illness. And there's also thinking about, everyone's anxious about COVID, understandably so, and we all need to be vigilant. And how do we differentiate that between a primary psychiatric illness? And especially for frontline providers who are most often serving pregnant and postpartum women, that is really complicated. The good thing about this is that we do have approaches, and some of the other, Dr. Wazinski had outlined some of the things they're doing as part of his project. And in general, our program is available for people in Massachusetts. And in general, there's lots of things that are being done. One, I think, example of something that can be really effective during this time period is trauma-informed care. This is really an approach meant to empower women. It's meant to be universally implemented. And this is something that can be very helpful, because COVID-19 is experienced by a lot of people as a traumatic event, and people also, and you can have that on top of prior trauma as well, as we've heard about. And so that's a really important approach that can be helpful. The other thing that can be done is educating, preparing women, and also providing choices. COVID has certainly taken away all of our choices around our everyday lives and our ability to do meaningful and enjoyable activities. There are still choices people can provide, and the more that the healthcare system can help women have choices around things, that can be helpful as well. And also, there are a lot of mental health treatment and other supports available. So to give some examples, Postpartum Support International, They have done groups for years. They are now having groups online. Many, many people are starting groups online. Most mental health providers are doing telemental health or telepsychiatry. And there's also lots of other supports that can be available. And the other thing we can encourage people is that, yes, physical distancing is important. That doesn't necessarily mean that we have to socially disconnect. So we can do physical distancing, but socially connect. And the two don't have to go hand in hand. And there are ways to do that. And on our website, MedPrep for Moms, we do have some specific resources around COVID and mental health, and also some resources for providers that may be helpful. So in summary, the COVID-19 pandemic is creating unprecedented challenges, and it's also exposing long-standing inequities and gaps in healthcare in Massachusetts, where I'm most aware of it living here, but also across our nation and also across the world. I hope that this puts a fire under all of us to be addressing health equity. There is very little about health equity as it relates to mental health, and the pandemic is certainly exposing a lot of these health inequities. And certainly our group is focusing this, and we hope that others will be focusing on mental health inequities. It's an opportunity to implement trauma-informed care. And the other piece where there's opportunities is integration into the electronic medical record and use of technology in general. This pandemic has certainly, in medicine, it has certainly forced many people who weren't necessarily comfortable with technology, and whether it's doing a survey over email or using a portal, or whether it's having a meeting with a patient using telehealth, that has been exploding, and there's room to improve on that. And actually, as it relates to mental health, what we're seeing anecdotally, and I'm seeing this across all the programs at our institution, that, and other colleagues I speak with, that people are consistently actually, it's sometimes increased access because telehealth, people can take it. They're able to do telehealth. Even if they can't do it on video, they can do it over the phone. And what we're seeing is our engagement rates and our participation rates are much higher. So I think we're now going to move on to questions. And thank you.
Thank you very much to all our speakers. So we already had some questions in the Q&A, which are actually pretty aligned with some of the questions that we had received prior to the panel. So just to get us started, each of you highlighted and gave an overview about some of the common concerns for, pregnant women and their families. I'm wondering if you could tell us a little bit about, what do we know about risk factors that could increase COVID-19 infection-related complications for pregnant women? Sonia, would you like to start with that?
Sure. So to study that, we will need even larger sample sizes to look at risk factors based on what happens outside pregnancy. Things like diabetes, respiratory conditions, smoking are expected to be risk factors. In the American Society for Asthma, Allergy, like the 4ASI and Immunology Society, there is a link with information for women with asthma. So, but many of these concerns are extrapolating from what we think is going to happen, not that makes sense physiologically, not that we have large cohorts to show it. Yeah, but I would say respiratory conditions, smoking, cardiovascular diseases like metabolic diseases like diabetes are expected to complicate the severity of the infection.
Diego, would you like to add to that?
I want to emphasize something that I think Sonia hinted, which is there's very little that we know about the disease in general, about COVID-19 in general, and more specifically in pregnancy and the postpartum. Just recently, a few days ago, the CDC declared that pregnancy makes this population vulnerable. Before that announcement of 4 or 5 days ago, according to the CDC, pregnant women were not vulnerable. Why is that? Did anything change? Well, not really. Our amount of information that we have at the moment is very, very limited. So I think that they are trying to err on the cautious side. And what both the CDC and the WHO are trying to do, and many governments as well, is to encourage people like ourselves like Nancy, like Sonia, like myself, to do prospective studies, to try to test whether the hypothesis that the pregnant woman does not have an increased risk of the complications of COVID-19 is true. We don't really know. We need to collect data, we need to do our studies, and only then we will be able to say it with certainty.
Nancy, I wondered, would you be able to comment on if there are particular risk factors that might exacerbate mental health concerns, particularly, you know, as Sonia highlighted, there's certain kind of interventions if a baby has the virus that require isolation, changes to breastfeeding plans. You know, we think about, you know, there's of course the loss of kind of the, you know, planning and the wishes that the family and mothers want, but there's also, you know, skin to skin contact is something that is, you know, recommended. So as babies and moms are separated to sort of preserve physical health, what are some potential risks in terms of the mental health impact for women who are pregnant and postpartum?
Mm-hmm. Yeah. So, I mean, the biggest predictor of depression or any psychiatric illness is the history of that illness. So I think when someone has a history of illness, that's going to be a predictor. And if someone has a history, so during pregnancy, if someone has, you know, things don't get better postpartum. So the biggest predictor of postpartum depression is a history of depression in pregnancy. And actually of women with postpartum depression, 2/3 of women actually enter delivery with pre-existing illness. So that's also a very big predictor. And then there's all the things we've been talking about. There's risk factors that we know are there in general for postpartum depression or for perinatal depression. And then all of the things you just mentioned. I think one of the things that we know and what is so hard in general, regardless of COVID, about having a baby is there's a lot of lack of control. And people, you can't control whether your baby cries. You can't control whether the baby has colic. And for some people, depending on their experiences in life, and then there's the whole ghost in the nursery concept where it brings up, it rocks someone's marriage or their whatever relationship they have and their whole world. And then on top of that, you may not be able to bond with your baby. Like, you could still bond with your baby, but there's barriers to doing that potentially. And then you have physical barriers, you have social isolation barriers. And I think those are all the pieces that I think make this so challenging. And I think part of so those are all risk factors that just contribute to people experiencing perinatal depression and anxiety during this time period. And I think one of the key things is, do people have ways to cope with that? Because we can't control all those things. What I often tell women is what they can always control is how they react to things around them. And so that's something that I think can mitigate that risk, but that's a skill that needs to be learned. It's an important skill set, but many people haven't developed that skill because it's very challenging.
One of the things that, you know, we know of a lot of resources that some of which you mentioned, and I wonder if you could reiterate for us, you know, what are some signs of anxiety or depression that women may sort of kind of self-monitor for, their families might monitor for? I know it's, you know, integrated into routine prenatal checkups, but are there ways in which women or their partners and families can self-monitor? And here in the US, you know, you mentioned MCPAPs. What would you recommend if women are concerned about, you know, their own mental health? What would you recommend for them in terms of seeking additional support?
Yeah, it's both great questions. So for self-monitoring, it can be really challenging because I can't tell you, most times when I see women, they have been struggling for decades and never have had any treatment because they don't know. We cannot expect women to know. Like, we would never ask, are you diabetic? Well, they said, no, good, we'll move on. You can't ask someone, are you depressed? They don't know. So I think one of the ways is, you know, symptoms of depression. So if someone feels, the two key symptoms are, is their mood depressed more days than not? Are they feeling like they can still do activities, but they don't, it's hard to do them and it's a struggle. And do they enjoy those activities as much as they used to? That's a key symptom, is if they're not enjoying things like they have in the past, or if it's hard to motivate to do them. Depression also impacts people's sleep, their appetite, it has physiological impacts. And then also it affects the way people feel about themselves. So for example, a mom or expectant mother who felt previously confident, maybe it was a planned pregnancy, maybe she wanted the baby, and maybe she felt confident about that, all of a sudden feels like she's a bad mom, feels like she should give the mom to her mother because the baby's better off with her mother. or feels that, and there's often a lot of things that happen around breastfeeding, around people feeling that a lot of anxiety for breastfeeding, which I think, as you mentioned, the challenges around not being able to breastfeed and being taken away can be extraordinarily challenging. So those are kind of some of the things that women can notice. And of course, if women have thoughts that their life isn't worth living, that is always a sign that they should be, seeking support. And then it can also affect, as I mentioned, people's sleep and appetite and their energy level. And then I think for anxiety, people, I think a lot of people are anxious about COVID. I think the difference is what we look at is it impacting their functioning? So if someone's not doing something because they feel so anxious, that's not something they're not supposed to do because of COVID. That's where it gets tricky. So if it's something that the CDC says is okay, and we know it's like, are they still doing those? Is it preventing them? Is it how much time a day are they spending worrying? And also are they, yes, COVID's scary, but is it getting to the point where they're catastrophizing? So, and that can be really tricky to differentiate. But I think, and also it doesn't affect them physically, because with an anxiety disorder, people physically feel different. They may have heart palpitations. They may breathe more quickly. They may feel sweaty. That is not something we'd expect if you're worrying about COVID. That would be something that often needs treatment and support. And then to answer your questions about resources, so yes, in Massachusetts, our program, it's, any provider of a pregnant or postpartum woman in Massachusetts can call. It's 855-MOM-MICPAP. We're open 9 to 5 Monday through Friday, so people can call us. We can refer to therapy or consult around medication management, and we provide trainings. In the rest of the country, because actually the Access program has become a national model, there's now programs throughout the country. So actually on our website, which is Lifeline for Moms, if you Google Lifeline for Moms with a numeric 4, not FOR, we have a website of all the Access programs throughout the country. There's now 14. So any provider from throughout the country can, if their state has an Access program, they can call their Access program and get training and consultation and potentially resource and referral around this. And then also Postpartum Support International has a consultation line where providers throughout the state can call and get consultation. They also have a warm line for women where women can call for resources around to get therapy referrals. And I would say that's what we recommend in our toolkit, I think that's probably the best resource that can be accessible, anywhere. And both for providers calling and also for women with having these experiences that are calling. And they also have a lot of support groups as well through Postpartum Support International.
Great. We will compile the resources that each of our speakers have noted today as a resource list on our forum series website, as well as this recording will also be posted. And Diego, you mentioned that there are, through the online platform, there are opportunities for people to get consultation and also to connect in terms of virtual supports. Could you comment on resources available through the platforms?
Yeah, I can speak specifically about the platform we have, which is, unlike Nancy's platform, ours is international, which means it's available in 12 different languages. It takes into account the geopolitical differences between the different populations and regions. And essentially what we want to offer people, both women, their family members, their friends, healthcare providers, and government officials, is the opportunity to find in a single place the information that they need to make decisions. That could be in the form of articles published in the scientific literature. That could be in the form of news, could be in the form of videos, blogs, in the form of simply having someone to ask a question who will answer the question within 24 hours. In other words, the availability of information now in 2020 is immense. We started with the COVID pandemic only 6 or 7 months ago. Already by February or March, we and other colleagues of ours had platforms available for people all over the world to answer questions. So what I would say is, whoever has a need, either of information or who has a need to provide information and share the information, or who simply wants to have a friend, get in touch. there are multiple channels, there are multiple platforms for you to be in touch with other people like yourself. And they can be even in the same language you speak. I speak Spanish, it can be in Spanish, it can be in Urdu if you're from Pakistan, or it can be in traditional Chinese if you're from continental China, or simplified Chinese. And so it is, in summary, reach out. There are a lot of different opportunities for you to have information you need.
Thank you, Nancy and Diego. The other question that one of our audience members asked is, what do we know about the effects of the coronavirus on newborn health and development?
So I can take that. There are some publications with case series with like more than 50 cases that have been described, and typically they recover even if they have respiratory illnesses. They are discharged within 2 weeks. That is not to say that we are not going to see complications, and we of course don't know about any potential long-term consequence of the virus or the respiratory disease. But like for pregnancy, there are so far no reason to believe that they have a very high risk of having very severe responses to the virus.
And as you noted, we will need both larger scale but also longer term prospective studies to sort of continue to assess that. And finally, I wonder if Nancy, Diego, and Sonia, if you could comment on what are known kind of effective treatments in terms of mental health concerns. So you noted a number of resources, which include both resources for providers to consult, about women they might be working with, social connectedness and support groups for women to reach out about, platforms and other kind of access lines that Nancy highlighted, that allow women to call and potentially get, triage for further evaluation. Thereafter, in terms of kind of the current evidence for effectiveness of, addressing perinatal mental health concerns, so there's therapy or medication, could you speak sort of broadly to what are some effective treatments?
Yeah. So I would say that, what we have would be very similar to what would be without the, before the pandemic. So obviously with the kind of focus, I think trauma-informed care is a really important evidence-based. That's something that is implemented, can be implemented, for example, universally in an OB setting, but it's also something that we can integrate as part of psychotherapy. So, but I think the mainstay of treatment, as you outlined, is, therapy and support options. And then medication treatment. So for therapy, the evidence-based psychotherapy that we know have strong evidence base in pregnancy and the postpartum period is interpersonal psychotherapy and also cognitive behavioral therapy. And that, I would say those would be the same recommendations that we have during the pandemic. And then for other support options, so lifestyle changes, for example, healthy diet and exercise, encouraging women to do things like that, self-care. I'm a huge proponent of sleep hygiene. That is an evidence-based intervention, and sleep is such a critical thing to be doing for self-care during pregnancy, and especially in the postpartum period. Well, tricky, because part of the recommendation is not to nap. I'm not gonna tell a postpartum woman not to nap, but there are still those principles of sleep hygiene could be really helpful. And then also, mindfulness meditation and other things. There's a workbook that I love that I recommend people called the Pregnancy Anxiety Workbook by Pamela Whitescard. That's something that can be easily accessible at $15 on Amazon. So that's something that's like a nice non-medication thing that can be done even if someone's having trouble accessing therapy. And then for medication treatments, antidepressants are an evidence-based treatment, that is still an evidence-based treatment during pregnancy and the postpartum period. And I would say in pregnancy, one of the things we're thinking about is does exposure to the effects of exposure to the illness for mom and baby outweigh risk of exposure to a medicine? And usually when I'm seeing somebody, I'm very concerned about the illness, and I'm often much more concerned about that than the risk of exposure in pregnancy. And I'd say for lactation, generally, antidepressants are considered a reasonable option during breastfeeding. And the general thinking is that the benefits of the breastfeeding outweigh the risk of any passage through the breast milk. So I think I'll stop there. That's a high-level summary of what I would say the evidence-based treatment options. And these things are still available to women. People are doing telepsychiatry and telehealth. And I think people think I can't get it. Nothing's available during COVID. But these, I think, differs per state. Definitely some states have different, it depends on how reimbursement's happening. But generally, I think these treatments are often still accessible.
Diego and Sonia, any final thoughts around that or final comments as I hand it back to Karestan?
My final comment is pregnant women and women who are recently pregnant usually don't live in complete isolation. They have also other family members, especially other children, and that's an added stressor. Yeah. So if you have an opportunity to help a pregnant woman or a woman who has a baby in any way, maybe shopping, maybe taking the dog out for a walk, please do so. There might not be the effective therapies that Nancy was talking about, but for sure they will help. And we know because we get all those quotes, all those testimonials, they say how difficult it is. They are pregnant, there's COVID around, and they also have children. They have a partner. Sometimes the partner is not very helpful. They have elderly parents. How can you help in that situation? That's a question that we should all be asking and doing something about.
I completely agree. And psychosocial supports is a key part of those non-medication support options. I completely agree.
Well, thank you, everyone. I feel like we could have kept talking about this. We could have used a couple more hours. And just as a comment on the survey that Diego and Sonia were mentioned, we started the analysis, and 40% of women, no matter where they are in pregnancy or postpartum, up to 6 months, are screening positive for PTSD. But it's over 70% are screening positive for depression. And which is even high, even if you the elevated rates. And I just checked before this so I could make sure I was accurate. If we look, we have different countries, and if we look at countries where we have substantial numbers, which is US, China, Mexico, and South Africa, I just looked at 4. This is consistent in all those countries. So it's just to highlight the level of distress that women are feeling that Diego highlighted in his in the qualitative data that he talked about. So thank you so much. Thank you, everyone. And if people feel free to share this. Like I said, this will be online usually in a day or so, and you can join us next week. Not next week, on our next forum, July 15th, will be on the other end of the age spectrum. It'll be on creative coping for older adults during COVID-19, how to stay safe and sane. So thank you, everyone. Thanks, Diego, Nancy, Archana, and Sonia, and everyone take care. And we'll see you in a few weeks. Bye.
Okay, bye. Thank you.
Thank you.